Today, make sure you message us the word schedule if you would like a link to our events page, and also message free trial if you'd like a link to the free trial. We want to make sure and get you guys plugged into our platform, whatever that may look like for you guys. And this live will be on demand on Facebook and YouTube when we're done, so you can always come back and use it as a reference in the future. Be sure and drop your comments or questions in the chat. We have our content experts moderating the chat for you guys today. And last but not least, let us know where you guys are joining us from. Anyone here in the US, any international viewers, let us know. All right, well, that's kind of all of our housekeeping. Oh, I think we're working on the sound. Sound is good now, so we should be good. Thank you for letting us know. Okay. We are going to pull up an image on anxiety. So we're going to kick things off with anxiety today. Starting with the pathology of anxiety, we're going to start off by discerning between normal levels of anxiety and generalized anxiety disorder. So anxiety is something we can all experience. I'm sure if you're in nursing school, you experienced this maybe before a test or before performing a new skill. Definitely like those skills checkoffs. Those are high anxiety situations. Even thinking about your NCLEX, I get that. So anxiety related to these types of stressors is totally normal when the anxiety is proportional to the stressor and it resolves after the situation or the activity is complete. The difference though with generalized anxiety disorder is the worry and anxiety is excessive. So it's going to go above and beyond what the situation demands. That anxiety is not limited to one situation either. It's going to encompass all aspects of life. So that can include family, children, work, everything going on. And the amount of worry these clients experience is frequent, meaning it happens most days of the week. It's not just situational. And generalized anxiety is going to come with physical symptoms too. So feelings maybe of feeling queasy or faint, having a headache, racing heart rate, heavy breathing, sweating, anything like that. And then this anxiety is going to spill over into our clients' responsibilities, and it might even impact how they function at work, how they interact with others, and just their general overall health. So in terms of risk factors, there's not really a specific cause linked to generalized anxiety disorder. So it could be a combination of genetic, psychological, and even developmental factors. Okay, so that's kind of setting the stage of anxiety. Let's talk about manifestations. So what is it going to look like? Our clients with generalized anxiety disorder, they're going to be in a constant state of fight or flight. So this is going to look like difficulty concentrating. Their mind's going to be racing, feeling on edge, just super anxious. And we want to think tense. So tense heart with tachycardia, so an increased heart rate. Tense muscles, not being able to relax, and a tense mind, so difficulty sleeping or difficulty concentrating. So what are we going to do as a nurse? How are we going to help these clients? We're going to give you some key words about all of our different topics today. So for anxiety, we're going to think stay and calm, or stay calm. So as a nurse, we want to stay with the client and keep them calm. We never want to leave them when they're in a heightened state of anxiety. We want to instruct them to take slow, deep breaths. And there's also medications we can use in these situations like benzodiazepines or SSRIs. These are used to treat anxiety. So if an acute anxiety attack is taking place, we can give quick-acting meds to help the client. We can also do cognitive behavior therapy. This can be used to help prevent these episodes from happening. So what that looks like is we want to help the client identify what's going to provoke that anxiety in them and identify it before it elicits that anxiety. So kind of identify those triggers. That's really what it comes down to. Then we're going to instruct the client to challenge those thoughts and replace them with more realistic thoughts. So we can use like public speaking as an example. So public speaking is not everyone's cup of tea. So this is kind of like how we would walk through cognitive behavior therapy with that. So the client might say, I'm going to mess up and everyone's going to think I don't know what I'm talking about. So over time and with practice, what a good response to the cognitive behavioral therapy would look like is if the client reframed this feeling and thought, I have prepared the best I can and I know this information like the back of my hand. So that would be like a therapeutic response to that kind of anxious feeling or that thought. We also want to encourage stress reduction techniques like journaling, exercise, deep breathing, any hobby that the client enjoys that can help. All right, that was kind of our summary of anxiety. So again, remember that theme, stay and calm. We just want to reassure that client. We want to bring their energy level, that heightened anxiety down a little bit. Okay, so we're going to move on to depression next, but I want to kind of quiz you guys about what you might know about depression. So what are some of the clinical features or manifestations of depression? So what will a client with depression look like? So go ahead and drop that in the chat. And I see that we have some viewers that have test anxiety. That is a very common thing, something we all experience, especially probably going into the NCLEX. We have a ton of great videos you can actually check out on all of our channels about some of those, some ways to help reduce that test anxiety, especially just doing as much as you can to be prepared before you go into any type of test. So knowing where to go, where to park, what you can bring in, all that kind of stuff. I'm seeing low mood, loneliness, fatigue, loss of motivation, appetite changes, all great answers. Good job, you guys. Well done. Okay, so we're going to bring up now an image for you guys about major depressive disorder. So let's kind of talk about this. Let's talk about what leads to a diagnosis of major depressive disorder. We can define major depressive disorder as persistent, meaning more than 2 weeks of a change in mood, like feeling down or sad or having a loss of interest in daily activities. So knowing that, let's talk about what happens in our brain that can lead to depression. So clients with depression often have a deficiency in neurotransmitters in their brain. So specifically the ones that are responsible for mood. So thoughts and behaviors, and they also are going to demonstrate a significant impairment in daily functioning. So some of these neurotransmitters are going to be serotonin, which is most commonly associated with our mood. Norepinephrine, this is what helps us take action in a fight or flight situation. It's like an activator for our body. And then dopamine, which is related to pleasure. So we have some risk factors that are important to know about depression. Genetics can play a big role in depression. A family history of depression can increase that risk for depression. Stressful life events can elicit depression. This could look like anything from job loss to relationship changes. Substance use, especially if a client goes from a high that was brought on by a substance and then they kind of come crashing down, that depressive mood can actually lead to more substance use, and it's just going to kind of be a vicious cycle of highs and lows. Grief or loss, especially unresolved grief or loss. Medical conditions or medical diagnoses can lead to depression. So think about some of those chronic illnesses like MS or Parkinson's, or even a terminal condition like metastatic cancer. And then being sedentary can also increase your risk for depression. If we don't move our body, we're not encouraging our body to release some of those endorphins. And we know those endorphins really affect our mood. Okay, so we kind of talked a little bit about the patho with our neurotransmitters, some risk factors. Let's move on to what we kind of talked about at the beginning, which are some manifestations of depression. So depression can affect clients of all ages, from children to older adults. It's important to recognize that it's not a one-size-fits-all age groups condition. And another thing too, depression is not a normal part of aging. So we should remember that when we're caring for older clients, if it's not typical for an older client to be depressed, we shouldn't expect that. We should be able to identify it and help intervene and treat it. So kind of starting with the top of our body, working from our head down with our brain and our mind, we can have sleep disturbances with depression. So either sleeping too much or even too little. We can have feelings of guilt or worry, worthlessness, trouble concentrating and being forgetful. A lack of interest in activities that used to bring the client joy. We can also have weight changes from not wanting to get up and move. So we can have changes in our appetite too, either consuming too much or too little. And then we can also have constipation if we're sedentary, so kind of linking it into our GI system. And then we can also have thoughts of self-harm and harmful behaviors. So we're going to talk about this a little bit later, but our main priority when we're dealing with depression depression is we want to keep these clients safe. If they express these feelings anytime about thoughts of self-harm, we have to know that this is an emergency, it's a priority, it's something we need to act on and to ensure that we're going to keep our clients safe. Another thing to note too, kind of as you're thinking about depression and other diagnosis, like differential diagnosis, so things that present similarly that we would rule out, depression can often present very similarly to hypothyroidism, so we need to be able to distinguish between the two. Okay, we talked a little bit about this, but let's talk about what medications we can use to treat major depressive disorder. So if you guys know those main classes, drop those in the chat and let's see what you guys think. A lot of people on today, so good to see all of you guys. Awesome. And I'm seeing a lot of the other answers that you guys put in about manifestations of depression. So good job. Right now we're looking for medications used to treat depression. So I'm seeing SSRIs. Good job. SNRIs. Good work, you guys. Good answers. All right, well, you guys kind of got it. Let's talk about some interventions and we'll touch a little bit on medications. So again, common meds for depression are going to include those SSRIs. So again, bringing it back to those neurotransmitters, those are going to be our selective serotonin reuptake inhibitors, and SNRIs, which are serotonin norepinephrine reuptake inhibitors. We say this a lot, but the priority intervention for depression is going to be safety. So again, when we kind of think of those keywords, anxiety was stay and calm, depression is going to be safety, especially if our client is having those thoughts of self-harm or harm to others. So as a nurse, we have to be able to ask these really tough questions and assess for this. So if a client says yes, that they are having thoughts of self-harm, we need to ensure and implement one-to-one surveillance. So this may be in person or virtual sitter. Regardless of the location the client is in, we need to be sure the environment is safe. So removing anything that can harm the client or others from the room if they're in a hospital. If they're home, we need to ensure that we're limiting access to weapons. And we need to be sure that the client has a safety plan if they develop thoughts of self-harm, and that they know what to do. So this will include knowing who to call that can help them, where to go if they need to go to the ER. For therapy, we can follow the same principle as with anxiety. So we can use that cognitive behavioral therapy to change negative thinking and reframe it in our thought process to implement more positive coping mechanisms. So we want to encourage these clients to get out of the house and participate in support groups. We want to encourage exercise and relaxation techniques, and we want to offer them positive reinforcement for progress in their therapies. In some cases, clients may need to explore ECT or electroconvulsive therapy as a form of treatment for depression. So we'll just move forward, call it ECT, so I don't have to have that mouthful of words. But ECT is performed in clients that have treatment-resistant depression or bipolar disorder. So when traditional therapies and medications have failed, ECT is a lot of times the best next option. So essentially what happens with ECT is the client is connected to a machine that delivers an electric current through the targeted area of the brain. So simplified, we're going to simulate a seizure in the brain. It's a brief tonic-clonic seizure, and while all this is happening, the client is going to be connected to monitoring. So EEG monitoring for their brain. It's like an ECG but for the brain. And then after that, the client may experience some adverse effects. But again, the main idea of this is to just send an electric current, almost like a restart, like hitting the reset button in their brain, and try and redevelop some of those pathways in our brain. So some of the adverse effects that can happen after this are going to be kind of similar to what we would see in a client in that post-ictal or post-seizure phase. So it can look like short-term memory loss. It's going to come back after a few hours, but it is something that can the client can experience. Nausea and vomiting, headache, confusion, being disoriented. But again, a lot of this is going to resolve in a short time frame after the treatment. All right, so we've made it through anxiety, we've made it through depression. Let's cover our last condition, which is schizophrenia. So schizophrenia happens when the client is unable to interpret or interact with reality normally. So think about expression outwardly is abnormal, so how they're interacting with the world is abnormal, how they're interpreting what they're seeing or experiencing is abnormal, and then this together is just going to generate abnormal emotional responses. So it's just a big misinterpretation of what's going on inside and outside. So the causes or risk factors of schizophrenia are largely unknown, but we can kind of associate it a little bit with some environmental and genetic factors, like kind of what's going on with our brain chemistry. So that's going to kind of lead us to what's next, which is our manifestations. So we're going to bring up a slide about schizophrenia for you guys to look at to kind of differentiate a little bit about what's going on. So when we say brain chemistry, we're referring to the neurotransmitter dopamine. So dopamine is largely responsible for movement. So we talked a lot about this in our Parkinson review session, which you guys can go back and check out, and reward. So again, dopamine is related to that movement and reward. So think about feelings of joy, motivation, or satisfaction. So clients that have too much circulating dopamine are going to have positive symptoms. So when we say positive, we mean extra, so like on top of their baseline. These extra symptoms are going to include hallucinations. So hallucinations are going to be based on our senses. So we can have auditory hallucinations, so thinking we're hearing things that aren't really happening or that are not audibly making noise, visual hallucinations, so seeing things, tactile with touch, and then olfactory, which would be smell. We can also have delusions. So delusions are based on beliefs and ideas, and then disorganized thoughts and speech. So some examples of this might look like loose associations, so loosely related thoughts. So this could look like, I like when I see carrots, orange trees are big, sunshine is my favorite. So you can kind of see how we're connecting color to the color of the trees, to the sun. It's all a little bit associated, but does not really make a whole lot of sense. Neologisms, those are like making up new words. Tangentiality, this is when the client kind of diverts from the topic at hand. They can't be brought back to focus. It's kind of just like a ping pong darting all over the place. Word salad, this would be like green butter day, singing December, just a bunch of unrelated words. And then echolalia, which kind of gives it a little bit away in the name, but think about echo, so just saying the same word over and over and over again, repeating a lot. We can also have disorganized behaviors, so that could look like catatonia, so unresponsive, sleep-like state. Maybe they're sitting or standing like in a strange or uncomfortable position. And then just kind of irregular movement, so jerking, twitching, anything abnormal from regular function. So those are some of our positive symptoms. Again, when you think positive, think about extra dopamine, not positive in a sense of like reassuring or good, just positive in the sense of too much. So now we're going to talk about negative symptoms. So in the same vein as positive symptoms, we're going to have too little circulating dopamine. So that's what's going to generate that negative symptom. So again, that's going to look like apathy. So apathy in motivation and activities of daily living, like hygiene, that's going to be a big one. The client may be asocial, so meaning like socially withdrawn. They can have a flat affect, so just being flat in their emotional responses, their speech, no kind of fluctuations in how they're talking, being really brief or curt, just no emotion. And then anhedonia, which means the inability to experience pleasure, and alosia, which means poverty or lack of speech. So just really not engaging in conversation and not saying anything. Okay, I always thought learning about the positive and negative symptoms was really helpful, but I want to know from you guys, what was something new that you learned about schizophrenia? Was it those positive symptoms, negative symptoms? Let us know. We love to know in the chat. I see someone did like the differences in the positive and negative, so glad we could be helpful. All right. Let's move on to nursing interventions. So what are we going to do for these clients? So again, our theme here is going to be trust. So for anxiety, again, stay and calm. Depression, safety. Schizophrenia, it's all about trust. So building trust through frequent short interactions. So we want to make sure that we're going to avoid touching this client. We need to set boundaries. We need to be very neutral when we're approaching them and how we're communicating with them. Again, think about these clients kind of falling either in that positive or negative end of the emotional spectrum. We want to meet them right in the middle. So if we're performing an intervention on the client, we want to explain that procedure to them step by step, or trying to give them small bits of information. We also want to start activities in a one-on-one setting. So in depression, where we want to encourage interaction with others, in schizophrenia, we want to focus on that one-to-one setting. So we don't want to kind of thrust them into like a small group setting or a group therapy setting. But let's talk about how we manage those hallucinations, since that's a really big part of nursing care for schizophrenia. So we need to understand more about what's triggering the hallucinations, and then we need to ask direct questions about them. So we would say, tell me more about what you're seeing. What are you hearing right now? And we want to prevent escalation of emotion from these clients. So we want to monitor for heightened anxiety or agitation. We want to decrease any stimuli that's around the client. This could look like removing them from a situation that's triggering them, or providing them with a distraction. Something like headphones can help a lot, or even small structured activities that can keep their brain focused on a task. We only want to speak about reality when we're communicating with these clients, so we never want to dive into the hallucination. You want to try and ground them and bring them back into reality. So a patient who maybe reports seeing spiders on the ceiling, they may ask you if you see them too. This actually happened to me with a patient I was taking care of. The patient was just like, "Do you see those spiders on the ceiling?" I said, "I do not see spiders on the ceiling, but what I do see are ceiling tiles. I see lights, I see alarm boxes, but I do not see spiders." We don't ever want to say, that is not, no, there's like, that's wrong, you're crazy. We don't ever want to say anything like that. We don't want to challenge them. We just want to bring them back to what we do see, and just simplify that I do not see what they're seeing. We also want to assess our client for thoughts of self-harm or harm to others if they're experiencing command hallucinations. So these hallucinations are where the client's they believe they're being told to perform a specific action. So we want to make sure that, again, we're implementing safety in that situation. All right, what do we do for delusions? Remember, delusions are based on beliefs or ideas. So this is going to include a lot of active listening. So saying back some of the things you're hearing, showing empathy, so sharing or relating to others. We don't want to argue with the client about their delusions or tell them they're false. Same idea with hallucinations. Anyone that's experiencing delusions are often pretty suspicious of anyone around them. So we want to take that opportunity for more to kind of take delusions out of the picture and really bring it back to trust. So this can look like offering them canned or prepackaged food so they're not concerned that anything was tampered with. We also want to open medication in front of them. Same principle. We don't want them to think that anyone's trying to sabotage their care or sabotage them. After they take their medication, though, we want to make sure and check their mouth and palms to make sure that they actually took the medication and they're not pocketing any medication. But we also want to make sure that if they are, we want to intervene if there's any intention of self-harm, like overdose, taking too much medication at once. So let's kind of sum this all up for positive symptoms. We want to this sums us up for positive symptoms. Let's focus on those negative ones. So again, our negative symptoms are going to be our deficit symptoms. So this could look like social skills training. So giving them tools they need to interact with others and engaging them and showing them that they're ready. We also want to help them with activities of daily living. So making sure their basic needs are met, and if they can't meet them themselves. And then, as with anything, we want to encourage them with positive reinforcement along their treatment journey. It's really all about those baby steps. All right, we did it, guys. We covered 3 major psych disorders, let's do some practice questions. So we'll bring up our question, I'll read it to you guys, give you about 30 seconds to answer, and then we'll talk about the right answer. You guys did great today. All right, the nurse is caring for a client who has been hospitalized for major depressive disorder. When the nurse reminds the client that breakfast will be served in the dining room in 20 minutes, the client says, "I'm not hungry and I don't like doing anything." What is the best response by the nurse? Option 1, "I will help you get ready, then we can walk to the dining room together." Option 2, "I will have breakfast brought to your room. I know you don't have much energy right now." Option 3, "It's okay. It is okay. You can join us when you are ready. Take your time." Option 4, "You will feel better when you get up and get dressed. You need to eat something." All right, 30 seconds on the clock. Drop those answers in the chat. You guys are doing great. I saw a kind of like a study tip for the negative symptoms associated with schizophrenia, the 6 A's. That's definitely a good way to remember it. I don't know if I could shout them all out, but definitely like apathy, alogia, all the other ones, plus 4 more A's. Good job, you guys. Awesome. Good work, good work. I'm seeing a lot of 1s, some 3s, a 2. You guys got it. All right, good work, you guys. Okay, so our correct answer in this one is going to be option 1. "I will help you get ready, then we can walk to the dining room together." So again, our client has major depressive disorder. This client is going to need some direction and structure performing some of those activities of daily living. Waiting for the client to feel more energetic and initiate activity and interaction on one's own is not going to be helpful in this situation. So we want to assist the client with some of these ADLs. It's going to help convey a sense of caring. It's going to provide an opportunity for interaction with the nurse, and it's going to help raise the client's self-esteem. So what we see in option 2, having breakfast brought to the room, this is going to kind of like it's not going to do us any good. It's not going to change what's going on with the client by keeping them in their room, keeping them secluded, not having them get up and move. So that's not the right answer. You can join us when you're ready. Take your time. We want to encourage this client. Again, that positive reinforcement. We, kind of have to get the client up and going. And so we really want to provide more of that encouragement and motivation versus, again, just kind of meeting them at that baseline they're at. And then in option 4, we don't want to tell someone how they're feeling and that, they'll get better if they do something. That's not the right therapeutic communication. So good work on that one. Correct answer is option 1. All right, let's do our second question, and that'll be our last one. The nurse is assessing a client with schizophrenia. Which of the following findings would the nurse expect to observe? Select all that apply. Option 1, apathy. Option 2, social withdrawal. Option 3, agitation. Option 4, ritualistic behavior. Option 5, anhedonia. Option 6, disorganized thought content. All right, drop those answers in the chat. Don't be alarmed that you have 6 options on this select all that apply. That happens sometimes. That's one of the alternate item types, and you can have many more than 5, I believe 10 or less. So it can happen. Just take it one answer choice at a time. Don't panic. Good job. Great answers, everyone. Good work. Good job, you guys. It's going too fast. I was trying to say some of your names. You guys are doing awesome. A lot of great answers coming in on all of our channels. So good work, you guys. And before we leave today, let us know if we have any new NCLEX passers or if your test date's coming up. We definitely want to celebrate you and wish you luck. All right. Good job, everyone. Well done. Okay. So you guys definitely got it. Our correct answers are going to be everything but option 4. So correct answers are 1, 2, 3, 5, and 6. So clients with schizophrenia can experience, again, those positive or negative symptoms during the active phase of the disorder. So we have a lot of negative symptoms here: apathy, social withdrawal, anhedonia, which is, again, that unable to experience pleasure. Some of our positive symptoms are going to be agitation or disorganized thought content. What we see in option 4, ritualistic behavior, that could be considered like compulsions. That's going to be characteristic of obsessive compulsive compulsive disorder, or OCD. All right, so good work, you guys. You did great. Be sure and come back on Wednesday and Thursday. On Wednesday, we're going to be covering pediatric questions. We're going to be doing a question drill. And then Thursday, most missed questions. We also have a slide for you guys about how to access more content on this on our QBank. So for all of our viewers that have already purchased UWorld, there's a short video that shows you how to navigate to more mental health questions. So go ahead, take a practice test for more questions on today's lecture content, test that knowledge, see how you're doing. If you haven't purchased UWorld yet, you can use this video too to guide you through the QBank on our free trial. As always, please visit us at uworldnursing.com. Stay tuned to what we throughout the week for all of our great content. Join us tomorrow, and thanks again for participating today. We'll see you next time. Bye.